Hello everyone, welcome back to the Medic Clinics. So this time it is orthopedics, and we're going to learn about the examination of the hip joint today in our clinical corner. So without further delay, let us start. Hope you're all eager for the class because hip joint is supposed to be one of the most important and most favorite exam joint of the examiners. One is the knee joint, the second. So you don't get A's as such in your exam, but they will lot of questions from the hip joint, right? So let us further delay. So before that, all the technicalities are right. The audibility, visibility, yes, they give a signal to us by their thumbs up sign. Okay. So as I told you that examination of the hip joint is like a very important. Now is that voice clear? Okay, med student, we will up into that. I don't know why some microseconds you're missing. Maybe because of that, my voice modulation, maybe, probably. Just recovering from the cold, so that could be the reason also. So now is it clear? Is this okay? This class. Chalo. Then I was telling about this hip joint and why. Yeah, okay, fine. Thank you. So the thing is here, the hip joint usually they won't give you in any exam. Like for undergraduates, it is not any case which is written. So it is actually a long case for the postgrad. So but they will ask you in form of X-rays. They will ask you in form of other various options, like they can ask you in case of instruments also. They will show you some instrument and then they will ask you where this is usually used, and what they ask you about is TB arthritis. So one of the most important one, and then dislocation of the hip, right? And coming to the trauma, IC fracture, the IT fracture, right? So these are all the important things which you have to make sure you're going to read this theoretical part before you're attending your viva sessions or orthopedics practical exam. And from the pediatric part, they usually end up asking questions regarding this DDH theory part. So as you are preparing for the orthopedics part of you, orthopedics point of view regarding your practical exam, you have to be pretty sure with the case first, and then from the hip joint, there are certain questions where they can ask you, even if it is not related to the case sometimes. So these are the important topics. So first you have to have little bit of knowledge regarding the TB arthritis, because there are stages in this, so they can ask you a question of that. And then dislocation of the hip is very important. Usually even NEET PG preparation also, this is very, very important topic. And also regarding the hip joint, this becomes one of the important topic, right? And then IC and IT fracture. So whenever they're asking you regarding the instruments and the implants, right? So there they will ask you these questions regarding your IT fractures. Okay, and then whenever they want to test the knowledge of your hip movements and various tests, then they can ask you about DDH also. So regarding the hip, these are some of the important topics, right? And now, so as I've told you, usually hip joint patient comes with pain, right? Swelling. So these are again the general things. And here they might come with gait abnormalities also, right? So these are usually the complaints about the patients with hip joint and restricted movements. So they will complain about functional disability as we keep on discussing. So whenever there are some deformities, there are certain functional limitations such as the patient cannot squat properly, the patient cannot sit on the floor properly. So these are some of the functional limitations which the patient can complain about regarding the hip joint. So the first and foremost would be the pain. But when it comes to trauma, so you are always should always inquire about the mechanism of the injury. Similarly, again, they would have pain and all other things, but whenever it is regarding the trauma, you have to inquire. And a certain important things such as, whenever you ask about this mechanism of the injury, right, you will understand what is the violence, that is force or magnitude of the force which is an injury. That you will be alarmed regarding the other things which you have to examine as the traumatic patients, right? But usually in the exam, they whenever they want to ask about this trauma, they don't usually put acute trauma cases because examine them, yeah? So they will usually avoid putting this hip cases, right? So now, so what are those important things which you have to understand regarding the hip joint as such? But I am pretty sure this is not usually asked in the exam as a case. Mark my words properly. Not usually as a case, but these all things you have to know whenever you're preparing for orthopedic practical exam. So as any other case, the hip joint also starts with inspection as well. And one of the most important thing in the case of hip joint is the attitude. So this is very, very important. So whenever somebody talks about the attitude, they usually want to test your knowledge about the dislocation of the hip. And what is the most common form of dislocation of the hip? Is it anterior or posterior? Which is the most common one? Yes. So whenever it comes to hip dislocation, the most common one is posterior, right? And whenever it comes to shoulder dislocation, so in shoulder, it is the anterior dislocation, which is most common. Okay. Right. And now can somebody comment on what is the attitude which is shown on the figure? So what is this attitude? Again, going back to the basics, what is attitude? Attitude is ease, right? Ease of the position. So whichever way the joint feels comfortable, it will lead to that attitude of the limb. So now what is this attitude which I am showing you on the screen? Yes. So this is nothing but your flexion, right? Adduction and internal rotation. So this comes to be the father, right? This comes to be the father. So flexion, adduction and internal rotation. This is father, and where it is usually seen very commonly seen in case of your posterior dislocation of the hip. So whenever it comes to hip joint, the attitude plays a very, very important role because it has few important attitudes which you have to remember. So here the first one we are going to learn about the father, that is flexion, adduction and rotation. This is the photograph of that particular patient who has come with the posterior dislocation of the hip. So by seeing this attitude itself, you can diagnose this case as posterior dislocation. And now what you do, you send the patient x-ray, and then after confirming, then you proceed for the treatment, right? So before that, you should also check for the neurovascular status, right? So what do you usually expect in case of posterior dislocation of hip? You expect a arterial injury or a nerve injury. Which one is the most common in case of the posterior dislocation of the hip? So whenever a patient arrives to the casualty with the posterior dislocation of the hip, the most common complication expected here is the sciatic nerve injury. The nerve complication we expect in case of your posterior dislocation. Hence, you have to check for the foot drop, right? So that is how it is important. The attitude is very, very important, right? So that is the attitude. Clear? Now next, what is this attitude? Now, other patient has come with the attitude of this. So this is which attitude? So now this is your flexion, abduction, and external rotation. Yes, very good. This is your Faber attitude. And where do you see this type of attitude? This type of attitude is seen in your anterior dislocation of hip. Right? So whenever we are talking about anterior dislocation of the hip, again you have to be very careful that this is also a high velocity injury. Posterior dislocation is also a high velocity. Anterior dislocation of hip is also a high velocity injury. So this is how the attitude plays a very, very important role. This is Faber and this is seen in anterior dislocation of. Now there is no flexion, there is no abduction, but simply what is this? This is one more type of the attitude which you can expect in case of the hip joint, and this is most common attitude which in the casualty. Yes, Harsh? So this is, yes, plantar flexion. So this is shortening and external rotation, right? So now what you have to check for this is the medial malleolus. Here is one more medial malleolus. So here you see there is some amount of shortening. So the limb has gone up, and if you see the lateral border is completely touching the couch. This is an example of the external rotation. Anterior dislocation we have already completed. No, this is the anterior dislocation. So in anterior dislocation, this also there is a flexion also you see, right? So flexion, abduction and external rotation. So here there is no flexion. What you see is just a pure external rotation. And if you compare the medial malleolus of the both the sides, what you see is shortening and external rotation. And this is very commonly seen in traumatic patients, that is intertrochanteric fractures, right? So this is a classical case of intertrochanteric fracture. If you remember, you have intracapsular fracture as well, but here the external rotation is minimal. Harsh, is this clear for you? So this is your anterior dislocation, flexion, abduction and external rotation. If you see only external rotation with shortening, this could be a fracture, that is intertrochanteric or intercapsular. But as you see, this is very, very important. As you see the lateral border, so this is called the lateral border on the little finger. So this is entirely touching the couch. So it is completely externally rotated. So whenever it is completely externally rotated, that means it is an example of an extracapsular fracture. So this is an extracapsular fracture because there is no capsule to hold the external rotation is complete. But whenever it is intracapsular, that is your IC fracture, because it is inside the capsule holds the external rotation, hence the external rotation is minimal. Understood? So these are the three important attitudes which you have to remember in case of the hip joint. So one is your father, that is flexion, adduction, internal rotation. The second one is the Faber for the anterior dislocation of the hip. And whenever it is IC fracture or an IT fracture, it is nothing but shortening plus your external rotation, right? So these are the three. Capsule is not joint space. Capsule is joint capsule. See, the synovial joints are enclosed in a capsule, right? It is a tough structure. Each joint, each synovial joint is enclosed by a whitish structure around the joint, which is called as the joint capsule. It is a tough. So you want to enter the joint, you have to cut open the joint capsule and then enter it. So the joint is enclosed by capsule, then this capsule is lined by your synovium. Okay? And the space between them is called the joint space. Is that clear? Yes. And after seeing the attitude of the patient, you should also examine for the gait of the patient, right? So gait, usually it is some complex topic, not very, very important for you. But one important gait which you have to remember is the Trendelenburg gait. So this is the Trendelenburg gait. We will come back after learning what is Trendelenburg test. Okay, then it will become easy for you, right? Till then, remember in the inspection, you have to see the attitude, and if the patient is able to walk, then you will test for the gait. So the most common gait which we see is called the antalgic gait. How to remember? See, whenever you get confused between any two things, remember only one thing. Okay, so please remember, whenever you see this picture, that is father, it is posterior dislocation of the hip. Faber is anterior dislocation of the hip. So I am not very good at forming the mnemonics, but I will teach you the mechanics so that you will not get confused. So what is actually posterior dislocation of? So this is the acetabulum and this is your hip. So this hip joint is going backward, right? So just imagine your hip ball, whatever the ball is there in your hip joint, it is going backward. So if it has to go backward, it has to turn inside like this and it, right? So whenever it is going backward, what is the position? It is creating internal rotation, that is adduction and internal rotation. This is the mechanism of injury. And whenever it is Faber is the ball has to come outside, right? So the ball has to come outside. So to coming outside, it will external rotate, right? So Faber is external rotation, that is coming outside. Anterior dislocation is forward, posterior dislocation is back, right? Yeah, if it is coming outside, the length sometimes will increase. Yeah, in Faber it will increase. Farther it usually decrease. But with the flexion, we can usually cannot, measure that increase and decrease. Okay? Yes. So just remember, father is posterior dislocation. Next, so here we are in the gait. So in the gait, what is happening is if the patient is able to walk coming with the pain or swelling in the hip joint, then what you have to do is you have to even inspect for the gait. The most common gait which we encounter is the antalgic gait. That means the weight put on the affected side is for shorter duration. So usually if we walk, no, if you see that we are walking, we put weight both equally, right? So we put a weight on the each side equally. But whenever you're having pain on this side, whichever I'm holding the pen side, so what you do, you don't try to put more weight and you remove it fast. Like this, you walk. So the weight which is put on this side is more compared to this side. So the time duration is right. So that is called as the antalgic gait. Antalgic gait is the most common. This one you have to remember. And there is one more called Trendelenburg gait that we will see after learning what is Trendelenburg test. So that is about the inspection. What you have to see is first you will see for the attitude, then you will see for any swellings. So in case of posterior dislocation of the hip, where do you feel the swelling? Swelling is present on the posterior. So swelling is nothing but that is a bony swelling, the head which is present on the posterior side. So again, you have to comment for any other swellings other than bony or any soft tissue swellings are present in case of your inspection. Then not to forget, always remember whenever you're doing inspection, you have to always talk about the muscle wasting. So this is very, very important in case of chronic cases which you deal. For example, in case of your hip, it is TB, right? You have to comment about the muscle waste. This is about the inspection. Then coming to the palpation. So now I don't want you all to, remember and take a lot of stress regarding this hip joint examination because this is purely a resident case. I mean, it is purely in a postgraduate case. We learn all this, but as it is given in your book, you have to be familiar with the terminologies. So whenever I talk about the palpation, so here you have to always start with the tenderness, right? And not to forget temperature. So this is for the acute cases. We don't deal with acute cases in the exam. So we don't usually comment for the temperature. And here most important is tenderness. And you will feel the tenderness in the anterior joint line. Just remember there is an anterior joint line, nothing more to be remembered, and you have to feel for the femoral head and press it over. So whenever you feel the pain or tenderness, so it is anterior joint line tenderness. That's it. And what I want here to understand is there is one triangle which you have to remember that is called the Bryan's triangle. That is called the Bryan's triangle. This is very, very important. So, as we have learned elbow joint, right? We have completed elbow, we have completed wrist, and every joint, whenever we are dealing with, we understand that there are some bony prominences, and we are taking help of those bony prominences to diagnose. For the elbow, it was the 3-point bony relationship, which helped to understand whether it was an extra condylar, I mean, it was a supracondylar fracture or an inter. Similarly, here we have certain bony points. First one is a very important, the greater trochanter, right? The hip joint. And then we have your anterior superior iliac spine. So these two are very, very important bony landmarks in your hip joint. So whenever you are dealing with the case of hip joint, you have to always completely open, I mean, completely expose the part is above the umbilicus, from the umbilicus, above the umbilicus to the feet, the complete and properly covering the perineal region, right? So the patient has uncomfortable while we are examining, and take proper consent, and then you start palpating the anterior joint line tenderness. So that is usually below the inguinal ligament. There you palpate for the joint line tenderness. Once it is tender or non-tender, you document it, and then you come for palpation the Bryan's triangle. So how do you palpate the Bryan's triangle? You again use the fingers like this. So the first finger you put it on the greater trochanter, then you look for the ASIS. So ASIS, how to palpate? So you start palpating from the pubic symphysis and then you come up laterally. So the first bony prominence which you feel is your anterior superior iliac spine, and then that is your anterior superior iliac spine, and then on the lateral side of the thigh, again you palpate on the lateral aspect of the thigh, and you will feel one more bony prominence, that is your greater trochanter. So you will mark the tip of the greater trochanter. Your tip of the greater trochanter, this is your anterior superior iliac, right? And now what you do is you have to, so this is a palpatory method, right? So what you do is you put the two fingers like that, and a third finger you drop. So two fingers, one on the anterior superior iliac spine and the second one on your greater trochanter, and thumb you drop perpendicular to the anterior superior iliac spine. So once you do this, you get a triangle which is called as the Bryan's triangle. So I'll repeat it. So first mark ASIS, then you mark GT, right? Then there is a line joining these two, and there one more line from the ASIS you have to draw perpendicular downward, right? So this line from the tip of the GT, the line which is touching your imaginary line, which is drawn down from the ASIS, this is very, very important, and this will tell you whether there is a proximal migration of the greater trochanter. Proximal migration of the greater trochanter. So you will put a finger on this, you will put a finger on this, and then you will see whether this distance is equal on the both the sides. So you have to compare it on the both the sides. So if this distance, the distance, for example, let us mark it as x, this x distance is very, very important for us. So whenever this x distance compared to the opposite side, it is less. So for example, let us assume that here it was 5 centimeters, here it is 3 centimeters, right? The x. So then you will tell that there is a proximal migration of GT. And what are the conditions where it could be migrated? Again, it could be any your IC fractures, your IT fractures, right? And certain non-unions, right? So there is some hip pathology which is happening. So that would have resulted in this proximal migration of the GT. So that is the importance of your Bryan's triangle. So this is one, this is the anterior superior iliac spine, and this is the GT. So this is line A is connecting ASIS and the GT, right? And then you draw a imaginary line which is perpendicular to the ASIS, right? So this is your line B. And then you connect this line B to line A at the level of GT, and this is called your line C. And what is important for us is this line C will tell that this GT has been migrated proximally, that it has come upwards towards the pelvis. So any problem in the GT will result in this migration of GT, right? Understood the Bryan's triangle? So they will not ask you much. They will just ask you, how do you confirm that there is a problem in the hip joint? So some problem in the hip joint or proximal migration in the hip joint. So this is tested by the Bryan's triangle. Proximal migration of. Here, anybody wants me to repeat? Clear? So this is the first one which is very, very important. You have to remember what is a Bryan's triangle, right? The second one. Similarly, in the inspection, there is one more important thing which you have to remember, which is called as the vascular sign of Narad. Right? Vascular sign of Narad. Good. So next is the vascular sign of Narad. So what is vascular sign of Narad? So we all have this habit of examining the peripheral pulses, right? So at the level of the hip joint, what we have to examine is the femoral artery. So as you all know, how do we examine a radial artery or a femoral artery? So radial artery, usually we palpate here. That is, we are pressing it against the distal radius. Similarly, whenever we press an artery against a bony surface, and then we feel for the pulsations, right? So here the bony substance which we are pressing the artery against, it is the femoral head, right? The femoral head is the one where we actually feel our pulsations of your femoral artery. So whenever there is a posterior dislocation of the hip, what happens is the head is moving away from the position, right? Head is moving posteriorly. So there is no bony surface where you can palpate your artery. So you can't press the artery over the head and palpate it. So what happens is, what you see, you feel that femoral pulsations are absent. It is not because the femoral artery is injured, but because of your posterior hip dislocation. This is called as vascular sign of Narath positive. So whenever you can't feel the femoral pulses against the femoral head, that is because of the dislocation of the hip, then this is the vascular sign of Narath positive. In case of your IC fractures or IT fractures, sometimes you feel that these pulsations are feeble. You can feel them, but they are feeble, right? So this is the importance of your vascular sign of Narath. The second point. So first one is the attitude, which they would usually ask in the exam, and then they will ask you about the Bryan's triangle. That is the proximal migration of the GT to, and to document the proximal migration of the GT. We have learned that. And the third point I'm teaching you is the vascular sign of Narath, where we feel this femoral artery in the femoral triangle, which is usually felt against the femoral head, right? So if there is absence of this femoral head, especially posterior location of the hip, then this is called as vascular sign Narath positive. Is absence of the femoral pulsations. In anterior dislocation of the hip, actually the head comes more prominent, right? So if the femoral artery is not disturbed, you can still feel the femoral artery. So that is why in anterior dislocation of the hip, most common injury you see is femoral artery. Right, in posterior dislocation, it is a sciatic artery, right? Sciatic nerve injury. So femoral artery injury is most commonly seen in anterior dislocation. Then you can feel the pulses. But posterior dislocation, you can't feel the pulses. In IC and IT, the pulsations are feeble. They're present, but they're feeble. Clear? So that is the third point, which is important in case of your hip joint examination. Yeah. When you can feel the pulsation, it means it is negative. Vascular sign of Narath is negative. Are we done with vascular sign of Narath? So, good. So now in palpation, so we have completed that we are going to look for the tenderness, then pulsations, then palpatory Bryan's triangle. Right? So these are the things you have to document in case of, that is your palpation, right? And then comes the movement. So here what you have to remember is, this is the hip joint which enjoys the maximum freedom, right? Maximum freedom of the movement. So all the movements are possible. All the movements are possible. So what are all these movements? You all know, that is flexion, extension, then abduction, adduction, and then it is internal rotation and external rotation, right? So flexion is up to 120 degrees, but this is with the flexed knee. Extension is about 15 degrees. Abduction 45, adduction 30. Internal rotation is again 30. External rotation is 40. So now what did you understand by this? So whenever you are doing all these movements, you have to remember this in case of your hip joint. It is very, very easy to remember. So the first one is the flexion. So you all know flexion, it is moving forward, right? So flexion is moving forward. But whenever the knee is in extension, you can only do it up to 90 degrees, right? So what you do, you flex the knee and then you can do complete flexion. So complete flexion is where the upper surface of the thigh is touching your abdomen, right? Like this in the below diagram. You can see this. So here the thigh will touch the abdomen. So whenever you sleep, supine position, and then you do this uh, yoga, no, touching your thigh to the abdomen. So that is your complete flexion of the hip. And extension is very minimal, that is only 15 degrees, and it is opposite to the flexion. So flexion is towards the abdomen, right? So extension is opposite movement to that. That is your extension, right? So here you can see, so there is a flexion and then you go back, that is your extension, right? And then abduction. Abduction is more. So you can abduct more up to 45 degrees. Adduct is you have to cross the midline. So that is up to 30 degrees. It is then internal rotation and external rotation. So this can be again with the flexed knee and with the knee extension. Both is there, right? With the flexed knee, you can go 30 degrees of internal flexion and 45 degrees of external rotation. So if you see, abduction and external rotation are more compared to adduction and internal rotation. That's 45 and 45. The rest is 30. What you have to remember, only one word, that is extension is 15 degrees. Right? And flexion is the highest one, that is 120 degrees. Is that clear? So these are all the movements in case of your hip joint. So these are the movements in case of the hip joint. You're going to examine the patient. So always I tell you, movements are to be examined in two things. One is active. The second one is your passive. Right? Active and passive. Clear? Everybody with me? Yes. Now, the most important thing in case of your hip joint is your deformities. So, deformities you have to, what is a deformity? What is an attitude? So, attitude is position of the ease. Deformity is also a position, but this cannot be corrected, right? So, ease can be corrected. So, whenever a patient is in attitude, you can correct that attitude, but deformity is you can't correct it, right? So, this deformity most commonly you see in flexion. So there is a condition which is called as FFD, that is fixed flexion deformity. So what do you mean by fixed flexion deformity? That means extension is absent. This is little bit of higher level, right? So just remember, only one deformity usually. So there can be any deformity. So as I told you, there could be a flexion deformity, there could be an abduction deformity, or there could be an adduction deformity, there could be an internal rotation deformity and external rotation. So whenever they say whatever form of deformity, that means the opposite movement is absent, right? And most common and most important for us is your fixed flexion deformity, right? So what is this fixed flexion deformity? As I've told you, that any deformity is absent of the opposite movement. So here the extension is absent, but how do you know it is the hip is in fixed flexion deformity? So this flexion deformity is mainly because of iliopsoas contracture. That also you have to remember. So iliopsoas is the muscle which is helping in flexion of the hip. So they can also ask you how to test the iliopsoas contracture or fixed flexion. The answer would be only one test which is very, very important for you. That is your Thomas test. Understood? So FFT, iliopsoas, muscle or iliopsoas contracture. This is tested by your Thomas test. Okay. So what is actually happening in this flexion deformity? So here what is happening is you have to understand that the hip joint goes into flexion, right? So here the problem is the hip joint is going into flexion. Here it is going into flexion, but this flexion deformity is masked because nobody can walk with a flexion deformity, right? Just do it as an experiment, flex your hip and keep walking. You can't do it, right? Body has to come up with another compensatory mechanism to make you able to walk with your two limbs. That is the uh, mechanics of the body, right? Whatever is the problem, it will make sure that you're working efficient. So here even there is a flexion deformity in the hip. What happens is now the spine takes the pain and it will forego its lumbar lord. So what will happen is not actually forego, it will exaggerate your lumbar lord. So now there is a problem in the hip joint and the patient is unable to walk properly, right? So now what is happening? Now the iliopsoas is attached to the hip and you know it is attached to the lumbar vertebrae also. Now what happens? There will be an exaggerated lumbar lordosis just to compensate your flexion deformity. Now what we are doing? We are asking the spine to relax so that we can quantify the flexion deformity. So that is what is called the Thomas test. So what we'll do, we have to make the spine, tell the spine that, okay, now we are examining the patient. So we want the flexion deformity to come up. So we will ask the patient to completely lie on the couch like this, completely relaxed. And now we will ask the normal limb. So normal limb to flex. So this is what is called the flexion. So it should flex as if it is touching the abdomen. The thigh is touching the abdomen. So this is called the flexion. So whenever you're flexing one limb, the spine also relaxes. And now on doing so, you can see that there is an flexion deformity. So normally, if you do it by on your own, I mean, if there is no problem in your hip joint and do it normally, what will happen is you see the thigh is now naturally touching the couch. There is no problem here. But if there is a flexion deformity, by doing this maneuver, you can see that this is elevated. So the thigh gets elevated, and this is the flexion deformity which you see. And how do you quantify it? You take the angle of the long axis of the femur like this and long axis of the couch. So this is the amount of flexion deformity. It could be 10 degrees, 20 degrees, 30 degrees. So you can even quantify. You can even quantify the flexion deformity with the help of the Thomas test. Right? So that is the importance of the Thomas test. You have to remember. And it is usually asked in the exam and by the examiners as so how do I identify the fixed flexion deformity? You identify the by test, which is called as the Thomas test, and you can quantify the test as well. That means you can measure the deformity as well. And what is actually the process? So here the flexion deformity is masked by the exaggerated lumbar lordosis. So you will make the spine relaxed with flexion of another normal hip. So whenever you flex the normal hip, what happens is here the flexion deformity comes out and then you measure the flexion deformity. That's it. Okay. That is your Thomas test. Is it clear? So is Thomas test clear? Yes. So that is about the flexion and flexion deformity. Then this is how you examine the extension. So this is how you examine the extension. Usually this is done in the prone position. So patient is turned into prone position and then you try to extend the limb. Right? So this is how you examine the extension. So hip extension is usually less, that is up to 15 degrees. And you have to remember this is the first movement to be lost in case of arthritis. First movement to restrict or loss is the extension. Right? So this is the one thing which you have to remember in case of your hip joint. That's the flexion and this is your extension. Right? And then how do you test your abduction and adduction? So abduction and adduction, you can do it by standing or also in supine position. So this is how you abduct, right? And similarly, you adduct. So this is, you have to both limbs apart. This is abduction, right? And when you bring two limbs together, that is your adduction. And similarly, you can also do it in the lateral position. You can also do it in the lateral position where the patient sleeps in lateral position and you can ask the patient to abduct and then do the adduction, right? So that is how you test for abduction and adduction. And even the internal rotation and external rotation is done both in extension and in flexion. So this is knee extension and knee flexion. So whenever it is an extension, you will just roll the limb. So you will do limb rolling. So internally you rotate, externally you rotate. And whenever it is in flexion, again you can see that this is how we do internal rotation and external rotation in case you're flexed, right? So you flex the knee and then you rotate it like this. So internal rotation and external rotation, right? That is how you test for the rotations in case of your hip joint. So these are all the movements. So here you can feel that there are some movements which are restricted, right? Some movements which are exaggerated. So you have to document every movement. So you have to fill up the table: flexion, extension, abduction, internal and external rotations, both active and passive. So what is the degrees of what? Whether it is abduction which is restricted, whether it is external rotation which is restricted, or whether it's flexion which is restricted, you have to document it. So based upon that, again, you can come and arrive at a diagnosis, right? Is this clear? So these are the moments which you have to note. And then coming to the measurements. So these are the measurements. So once you're done with the movements, then they usually ask you about the measurements. As you all know that there are two important types of measurements. So one is the true length and the second one is your apparent length, right? So what is a true length and what is an apparent length? So here you have to be very careful. So whenever you're examining or taking the measurements of the true length, the limbs has to be identical. The limbs are to be in identical position, right? For apparent lengthening, it is not required. So how do you measure the apparent length? So apparent length, usually what we measure is with this. So here umbilicus to the medial malleolus. So always you have to take the bony prominence. So this is your apparent lengthening. So where you go for the medial malleolus on both the sides. So you will first mark the umbilicus, then medial malleolus on the both the sides, and then you will measure. So this is just you put the tape here, and then you measure up to medial malleolus, and then up to here. This is your apparent lengthening. Then comes the true measurements where you have to put the limbs in identical position. So how do you know that they're in identical position? So you have to mark the anterior superior iliac spine at both are at same level. So you see that these both anterior superior iliac spine are at the same level, and now you measure it from your anterior superior iliac spine to the medial malleolus, right? So once these two are at the same level, then you measure on the both the sides, right? So both the sides you will measure from anterior superior iliac spine to your medial malleolus. This is your true length, right? Here what you take? You take the umbilicus. So this is, you take the umbilicus with the medial malleolus, and here you take the anterior superior iliac spine to the medial malleolus. Have you measured the apparent length and the true length, right? Here, any doubts? So when it comes to measurement, we have to comment on both true length and the apparent length. So for the true length, always the limbs are to be in identical position. So how do you know that? So there the ASIS are to be at the same level. Then you measure from the anterior superior iliac spine to the medial malleolus. And for the apparent, it is the umbilicus to the medial malleolus. So this is how you have to measure the length, right? Yes, clear everybody? Yes. Then comes again the measurement of the Bryan's triangle. So we have done that palpation methods of Bryan's triangle where we put the three fingers to length, right? And here we use the direct tape measurement. So now you mark the greater trochanter, that is the tip, and then you mark the ASIS, again the tip, and then you measure it. So Bryan's triangle is this. So this is your ASIS and this is your GT, right? So here you can see that there is a migration of the GT. So this is your ASIS and this is your GT, right? And now this is your perpendicular, which you draw like this. And this is the distance you have to measure, right? So whenever there is a decrease in this distance, that means there is a proximal migration of greater trochanter, which could result in shortening of the limb, right? So there could be a shortening of the limb, and this you see with proximal migration of the GT, that is with the help of your Bryan's triangle. And whenever you see that the distance between your GT and ASIS is decreased, so this line I'm talking about, so this line will tell you whether, so the line between GT and ASIS will tell you whether it is medial rotation or lateral rotation. So whenever there is a distance which is decreased, that means it is internally rotated. So whenever the distance is increased, that means it is externally rotated. So the line between GT and ASIS will tell you medial and lateral rotations, and the line between GT and imaginary line, that will tell you about your proximal migration, that is shortening of the limb. So this is about your Bryan's triangle. Okay, is this clear? Any doubts regarding Bryan's triangle? So this proximal migration of the hip is very, very important, and there are various lines which are helping you to confirm the diagnosis, right? So if you see that if there is a bilateral hip case, in case of your bilateral hip, so still now we are comparing. So by this Bryan's triangle is all about comparing to opposite side, right? So always you compare it to the opposite side. But if there is a bilateral hip case where there is both the sides, you see proximal migration of the hip. So how do you confirm it? Then you confirm it by help of your Neleton's line. So what is Neleton's line? Neleton's line is ischial tuberosity connecting to your GT. So now you draw a line where you take the ischial, most prominent part of the ischial tuberosity, then you draw a line up to ASCS. That is anterior superior iliac spine. Then it will touch the tip of the GT. Right, so this Nilletton's line will pass through the tip of the GT, which is normal. If it is not passing, then it is called the proximal migration of the GT. So this is in case of your bilateral hip cases. Understood? So this is the ischial tuberosity. So in case of bilateral hip, so whenever both hips are involved, you take the help of this Nilletton's line. So this is not comparative, right? So you are not comparing the opposite side. You're not comparing it with the opposite side. You're individually testing. So now what you do, you draw an imaginary line from the ischial tuberosity to the ASCS. This should pass through the tip of the GT. Not passing through the tip of the GT, that means there is some proximal migration of the GT, right? So that is the Nilletton's line. So very, very important. They will usually ask you in the Viva. So what is a Nilletton's line, right? Touching the tip of the GT. Then what is this? This is your Shoemaker's line. So first is Nilletton's line. The second one is your Shoemaker's line. What is Shoemaker's line? It is again comparison. So what you do here, there is a tip of the GT, anterior superior iliac spine, tip of the GT, anterior superior iliac spine, right? So GT and anterior superior iliac spine. When you draw both the lines, they should meet above umbilicus in the midline. Two lines from ASIS to GT. So these two are very, very important bony prominences. So one is anterior superior iliac spine, one is GT. So you draw a line, right, from the GT to ASIS on both the sides, and they have to meet above the umbilicus in the midline. So that is normal. This is normal. When they meet below the umbilicus, it is proximal migration, right? That is your proximal migration. So if it meets below the umbilicus, it is proximal migration. So we have learnt about the Bryan's triangle, Nilletton's line, Shoemaker's line, and the third one is your Cheney's line. Cheney's lines are very, very easy. Again, you mark your GT, greater trochanters, and then you draw the parallel lines. So if they are ASIS, GT. Horizontally you draw and they come up two parallel lines. So whenever you see parallel lines, it is normal. So when they converge, it is abnormal. So whenever the GT is coming like this, proximally migrated, what will happen? This will go like this, right? So now they are converging. So if it is converging, again there is proximal migration of GT. Migration of the GT. So this is your Cheney's line. So we are done with Nilletton's line, Shoemaker's line, and then your Nilletton, Shoemaker, Cheney's line. Then what is this? This is Maury's bitrochanteric test. And this is not for the proximal migration. This is for internal and external rotations. This is for mainly the rotation, right? So this is you measure GT, ASIS, sorry, not ASIS. What you do is pubic symphysis and the GT. So this measurement X and Y. So this is your GT, right? This is your GT and this is your pubic symphysis. So now you measure this and this, right? Which one is nearer? Which one, if it is internally rotated, then they become nearer. And it is externally rotated, they become far. So this is about your GT and your pubic symphysis. That is about your rotations. It's called the Morris bitrochanteric, and this is you test with the calipers. So which length is more or which length is less. So just for your rotations, medially rotated or laterally rotated, with the help of your pubic symphysis and the GT, you measure this, right? So that is about the lines. So one is your Nelliton's line, then the next one is your Shoemaker's line, and then one is your Cheney's line, and this is your Morris bitrochanteric test, right? And finally, whenever you see that there is a shortening, limb shortening, and then you have to understand whether this is femoral shortening or tibial shortening. So you know there is two components, right? So this is thigh component and this is your leg component, right? Sometimes what we do is we individually measure the thigh component and the leg component. Well, but usually we use this test, flexion of the knee, and then we see heights of the knee, right? So this is lower level, this is at the higher level, right? So whenever you see this discrepancy, this is mainly because of the femoral shortening. So whenever you see that knee not at same level, then this is because of the femoral shortening, right? So this is one more test which we use for understanding the limb length discrepancy. So this is called LLD or limb shortening. This is limb length discrepancy or limb shortening. So this shortening, you have to understand whether it is from a thigh component or a leg component. So now what you do, you ask the patient to flex the knee and you see the level of the knee. If knees are not at the same level, that is because of the femoral shortening. So there is some problem with the femur, hence there is limb length discrepancy. If the level of two are same, then that is because of your leg component. There is some problem in the tibia, hence there is this limb length discrepancy. Is that clear? So that is about the measurements and the movements. And now coming to the special test, which is very, very important. So the special test here is, first one is your Trendelenburg test. Clear? Any doubts in the measurements? The Bryans, the Nelliton, the Shoemaker, the Cheney's lines? Yes. So now one of the most important thing in case of hip joint is your Trendelenburg test. Very, very important. And here what actually we do is we test the abductors. What are the abductors of the hip joint? So there are two important abductors of the hip joint. So one is your gluteus medius and second one is your gluteus minimus. right? So these two are important abductors in case of your hip joint. So this is your gluteus medius and your gluteus minimus. So this is very, very important. And why it is important? Because maintaining the balance. So the hip joint is one which maintains or takes the body weight. So body weight is exactly passing through the center, right? So the weight is equally distributed on both the hips, right? And now these abductors also play an important role in case of your body weight, and usually they play an important role in single stance. That means single limb weight bearing, right? So abductors play important role whenever you test them while doing your single limb weight bearing. So this is the abductor mechanism. Very, very important. So you have to just think that this femoral head and neck is acting as the fulcrum, and this is the body weight is the load and abductor is the power. So whenever these two are equal, the abductor power and the load, this load is, so if you see this particular diagram, whenever we are standing on both the limbs, the load is exactly in the center. Load is exactly in the center, and as your fulcrum, the femoral head and neck is intact, so your abductors are also acting, so the body level is maintained, right? So when this comes to single leg stance, what happens is the entire load of the body is by one limb. So this weight is actually taken by one limb, and now because of your head and neck are intact, which is acting as fulcrum here, the power, the abductors has to be in full strength, in full power. I mean, like it, the muscle power has to be 5 by 5 to take this entire load. If the power is decreased, it can't take the entire load. This is what you have to remember in case of your Trendelenburg test. So here what you remember, the fulcrum is nothing but your femoral head and neck, right? And what is the load? Is your body weight. And now power is your abductor. So whenever there is weak in your abductor, so when there is no power, the load cannot be taken. So whenever the load cannot be taken, you see this sign which is called as Trendelenburg sign positive. So what is happening in Trendelenburg sign? So let us assume that this is a normal limb, right? So this is normal limb. So what is a normal limb? So here the patient is standing on his right limb, right? So this is the right limb and he is lifting the left limb. For example, let us assume, right, he's standing on the right limb like this. So because the abductors are normal here, so the power is normal, it is able to lift the opposite side, though the weight, so this has to take the entire weight, right? So this abductor has to act. Understood? So this is the weight which is taking entire, one is the weight. So this abductor should act, not this one. So here, because these abductors are normal, the level is maintained. So there is no problem in the hip joint. So the level of the hips are maintained, right? Now if you see, now this is taking the entire weight, but this weight cannot be taken because there is a weakness in the abductors. So now the abductors cannot lift this pelvis. So what is the work of the abductors? Lifting the opposite pelvis. So if there is a weakness in abductors, there is a dip in opposite pelvis. That means the power is not sufficient. So what is actually this power doing? This power is actually lifting the opposite pelvis, but here because it is weakened, it cannot lift the opposite pelvis, hence this is seen as a dip in pelvis, which is called as the Trendelenburg sign positive. So what is positive? Positive means there is a dip in the pelvis, right? Which pelvis? Opposite pelvis, right? Opposite pelvis means if you take this as right, this as left. So you see there is a dip on the left side pelvis because of weakness in the right abductors. Right abductor weakness resulting in dip in the left pelvis. Right? Clear everybody? So the question will always be right abductor weakness, left pelvis dip. That is the question. So they will usually ask you which abductors are weakened, so that it is resulting in which dip. Okay. Yeah. That is the Trendelenburg test. So similarly, I have told you once we are done with the Trendelenburg test, I will tell you the Trendelenburg gait. So Trendelenburg gait, so there is a dip in the opposite pelvis, right? So we all know that because of the weakness of these abductors, there is a contralateral dip in the pelvis that you can see whenever the patient is walking. But to compensate this dip in the opposite side, what will happen is the patient will lurch on the same side. So now what happens, the dip is in the opposite side. To compensate that, the patient will put his whole weight, or to lift that pelvis, he keeps dragging like this. So this is called the lurch. So the shoulder is bending to the affected side. So shoulder is bending towards the affected side. So the bend in the shoulder is on the affected side, dip pelvis in the opposite side. So lurch is on the affected side. This is to compensate the dip. So to compensate the dip, he's using his upper body to lift it. So how do you lift it? You do like this, right? If you want to lift something, so like this he will do. So he will elevate the shoulder on the say opposite side. So similarly, they will be bent in the affected side. So this is called the lurch. So this is called the Trendelenburg gait. So contralateral, that is opposite hemipelvis dip with the lurch on the same side. That is your Trendelenburg gait. So that is your Trendelenburg gait. So that is your Trendelenburg sign, and this is your Trendelenburg gait. Have to remember these two things. That is it. And then one more important test is your telescopy test. So we are done with the Trendelenburg test. The second one is your telescopy test. Telescopy test is nothing but you're checking whether the pelvis, checking the stability of hip joint, right? So this is the test of the stability. So you're checking the stability of the hip joint. So what happens is whenever there is a dislocation of the hip, whenever the ball is not sitting properly in the acetabulum, you can feel this ball coming out of the acetabulum. For example, if the ball has shrunk to the small size, so there is a ease of this moving outside. So this is how you test. So you put the knee in flexion position, and then you use the thumb, you use the opposite hand, and then you do this movement, right? Like movement like this is called the telescopy test. So you do this to and fro movement into the acetabulum, and whenever you can feel that there is an ease of ball displacement, then that is called the telescopy positive. So the head of the femur can be easily displaced. This is very important whenever you're dealing with cases of DDH, right? That is the checking the stability of the hip joint. So that is one is the telescopy test. So here what happens, the surgeon has to stabilize the hip joint first, and then he uses one of his hand. So opposite hand he this and he feels this hand, he will stabilize the hip joint. So one hand you will stabilize the hip joint, so the opposite hand you will hold the knee joint like this, and then you do movement so that you can feel that ball is coming out. So with these fingers you can feel that the head is displaced, right? That is your telescopy test. This is for the stability of the hip joint. And now, not to forget, once you have encountered all this and you have answered it well, they will also ask you about Otterlany and Barlow's test, which are this test for your DDH, right? These are the test for your DDH, and these are used as the screening for the newborn. As you all know, what is Otterlany and Barlow's? So this is Barlow's test, your Otterlany, right? Barlow's is whenever you want to dislocate. So when you want to dislocate, so dislocation you already know, right? Whenever you want to dislocate, what is the mechanism of dislocation? Yes. So dislocation is father, flexion, adduction, and internal rotation, right? And Otterlony is Faber. So here what we are doing, we are actually getting the head out of the acetabulum. So we will internal rotate so that the head goes off the acetabulum, and whenever we do Faber, it sits in. So that is Otterlony. So we are putting it inside, that is Faber. We are getting it outside, that is father. So Barlow is father, right? And Otterlony is Faber. Yes, so these are the two important tests which they usually ask about the DDH, right? And then once we are done with the examination, not to forget how to read the X-ray. Reading the X-ray is one of the most important thing. This X-ray normal hip. So what you have to read, always start with inside or outside or inside. So you can start with the GT, outside, then LT, right? So this is your intertrochanteric region. This is your neck, right? And then this is your femoral head inside the acetabulum. So now this is your joint space. So the space between the head of the acetabulum, so this is the femur acetabulum and the femoral head, that this space is called the joint space, right, on the both the sides. And then you know this is your pubic symphysis, right? And this is your superior pubic rami, inferior pubic rami. Superior pubic rami, inferior pubic rami, right? These are certain normal things which you can identify here. And then what is important for us is this one, sentence line. So they will usually put up the X-ray and they will ask you to talk about the sentence arch or sentence line. So what is sentence arch or sentence line? It will tell you the continuity. It will tell you the continuity of femoral neck. Right, so how do you draw it? So you draw along the medial margin, so along the medial margin of the femoral neck. So this is the medial side, right? So this is the lateral side. So you will take a line along the shaft medial aspect of the femoral, which is going towards the inferior border of the superior pubic rami, inferior border of the superior pubic rami. So that is your sentence arch. So break in the sentence arch or sentence line is an indication of fracture or hip dislocation. So whenever there is a break, you can suspect that there could be a fracture or a hip dislocation, right? So this is how there is a break in the sentence arch. So if you see, this is the DDH X-ray. So this is the small head. So this is the actual head, this is the small head, right? So now if you see, there is a proximal migration of the GT, and then hence there is a break in the sentence arch. So this is actually the sentence arch. Now you see there is no continuity. So you say this as the break in the sentence arch. And now what is this? This is, there are two lines. One is the H line, the horizontal line, Hillengreen's line. Then there is P line, vertical line, which is the Perkins line, right? So this is H line, horizontal. How you draw? Through the triradiate cartilage. So what is a triradiate cartilage? Where your ilium, ischium and pubis meet. So you will identify a point. This is the triradiate cartilage, and then you draw a horizontal line. And what is the vertical line? Perkins line is the vertical line. This is along the lateral border of the acetabulum. Right, so this is your lateral border of the acetabulum. So draw a line along the lateral border of the acetabulum and one horizontal line towards your Perkins line, and now you divide this hip joint in 4 quadrants. So these are the outer quadrants, these are the inner quadrants, right? And these are the lower quadrants, and these are the upper quadrants, right? And whenever you see something, the femoral head in the upper outer quadrant. So upper outer quadrant is the DD head. Whenever you see something which is inner and lower is, so this is about the quadrants. And in case of DDH, this is the X-ray which they can put up, and this is not the X-ray of very small newborn. It is after 1 year, right? So this is the two lines which you have to remember in DDH. One is the H line and second one is the P line, Hillengreen's line and Perkins line, right? So this is the horizontal line along the triradiate cartilage. This is the vertical line along the lateral border of the acetabulum, which divides this into 4 quadrants, and upper quadrant is your DDH. So there is a dislocated hip, and in a inner lower quadrant is the normal position of your femoral. So the important X-rays. So you have to comment upon the sentence arch and then these lines in case of DDH. But in case of X-rays, so usually they put these X-rays. So what is this? So this is an intracapsular fracture, right? So this is an IC fracture. And what is this? This is an intertrochanteric fracture, right? IT fracture. So this is IC and this is IT. So if you see IC fracture, this is through the neck. So this is through the neck, right? IC fracture is through the neck, and IT fracture you see between the two trochanters. So your GT and this is your LT. So fracture between GT and LT is your intertrochanteric fracture, right? So these are the two X-rays which they ask, and this is sometimes you can see that there is an intact sentence arch in case of IC, and in IT, so that it is completely broken, right? The sentence arch is completely broken, right? So now they will ask you what could be the treatment for this. So usually the treatment would be hemiarthroplasty for the age more than years, and this is treatment be a proximal femoral nail, that is PFN. Okay, so, this is how your exam goes. So So they can ask you anything from the questions which we have discussed. Through the X-rays, they can take you through the X-rays, and they can ask you what are the important landmarks you see on the X-ray, and they can also give you a normal X-ray and ask you to identify what are the bony prominences here, and then they can ask you the Otterloni and Barlow's and some few questions related to DDH, and so that's it. So these are all the important things which you have to learn about your hip joint exam, right? Yeah. So any doubts you have? Anything you want me to repeat? So now we are coming up with the clinical corner. This is the clinical corner library we have on the app. So you can access this through the app. Go to the app, you will find a clinical corner. Then you can your favorite subject. I mean, whichever subject you want to learn the clinics of it. And then if you choose ortho, you have all these questions there. So you about non-union, malunion, osteomalacia. They're all the things where you can individually take the case, right? So this is the clinical corner. And that's it for today. Any doubts, you can pin me on Dr. Alekhya Ortho. This is the Instagram ID or WMeded. Do follow for more updates. And anything you want me to repeat, you can text. Yes. So if there are no doubts, let's wrap it for the day. See you all in the next class. Next class, I'll come up with the peripheral nerve lesions. Again, one more important topic. Hope to see you all again there. Okay, thank you.